Hi, everyone. Welcome to 117th Stanford MedAI Group Exchange session. This week, we have Mingjie Li from Stanford University here with us to talk about his work on graph-enhanced contrastive learning for chest X-ray report generation. Mingjie is a postdoctoral researcher in the Department of Radiation Oncology at Stanford University. He earned his PhD in computer science from the University of Technology, Sydney. And his research focuses on medical multimodal tasks with a particular interest in medical report generation and medical multimodal representation learning. So Mingjie, thank you very much for joining us today. Before we start, do you have any preference on how you would like to take questions? Can we interrupt you during your talk, or would you like to keep the questions at the end?
Sure, no problem. Yeah, welcome to give any question if you want. Yeah, okay. During my talk. Yeah.
Oh, thank you very much. In that case, let's try to make the session as interactive as possible. And without further ado, let me hand it over to Mingjie.
Okay. Thanks for the introduction and the invitation. I'm so proud that to give a talk here to introduce my work about dynamic graph enhanced contrastive learning for chest X-ray report generation. So this talk will contain 3 sections. Firstly, I will introduce the background, then introduce our work, which we name it DCL, and then I will discuss the future work. So firstly, I would like to introduce the medical reports. In clinical practice, medical reports are typically generated after some examinations and diagnostic tests, such as the imaging studies or lab tests. And this report will be crafted by healthcare professionals. And then they will analyze the test result, document the findings, and to provide some detailed summaries to give further diagnosis and treatment. It is a very heavy workload. When you go to the hospital, you may wait at least a few hours to get the report, or sometimes a few days, during the global pandemic, COVID-19. So why are the medical reports in clinical practice are important? The first importance is that it can be used for diagnosis and treatment. Medical reports provide detailed records of a patient's medical history, treat results, and diagnosis and treatment plans. So they are crucial for radiologists or physicians to make accurate diagnosis and formulate effective treatment strategies. And then it is also very important for the care and follow-up. Nurses and other healthcare providers rely on medical reports can track a patient's care needs and process. So these reports document care plans and can provide advice for personalized care plans. And it has also several advantages for communication, legal complaints, research, and insurance and billing. And in our work, we focus on chest X-ray report generation. At the beginning, it was named as medical report generation, which is a fundamental research topic in medical multimodal AI. It focuses on automatically generating medical reports to save the radiologist from heavy daily workload. Here is an example of chest X-ray image and its report, including findings and impressions. Recently, because there are lots of datasets focused on different imaging examinations, such as the X-ray, CT, rental image like FFA or OPT. So we call it chest X-ray report generation, which only focuses on the chest X-ray images. So what are the difference between chest X-ray report generation and the image captioning, which is one of the most similar tasks in the general computer vision? It involves the automatical generation of text for images, where the task is to produce a coherent and contextually relevant sentence that accurately describes the visual content. These captions are usually very short, and we can see that the objects in the images are usually at the center of located at the center of the image. And more important, it is obvious. So we can find the challenges. The first challenges in CRG is the most significant being severe visual data bias. The firstly is that visual homogeneity, because in chest radiology graphs, human tissues often appear similar with linear variations. This results in a data set where images have a high degree of visual similarity. Also, models trained on such data may struggle to differentiate between subtle difference, leading to reduced diagnostic accuracy. It means that if you want to train your model in the medical data set, you need some tricks to define what are the difference between the images. The second one is the small lesion challenge, because small lesions and anomalies, which are crucial for diagnosis diseases, but they are often occupy teeny regions in the radiology graphs. These lesions can be easily overlooked or ignored by models that are not trained to focus on small-scale variations. It means we also need to some tricks to focus on the small lesions. The last one is underrepresentation of rare conditions, because datasets often have fewer examples of rare conditions compared to common ones, leading to a bias towards more frequently occurring anomalies, and it will affect model to perform not well on the real issues, but very well on the common conditions. The second challenge in the CRG is the severe textual bias. The first one is also the report homogeneity, because in clinical practice, radiology reports often follow standardized formats and include common phrases or templates. This results in a high degree of similarity across different reports. So if you just calculate the similarity between different n-grams, you will get very high values of the matrix, which are focused on to compute the textual similarity only. And the models trained on such data may also generate repetitive reports, failing to capture specific findings. And that's why we call it bias from clinical templates. So here I will briefly introduce the medical report generation models for the related work. Medical report generation models often employs an encoder-decoder architecture, where the encoder processes input data such as medical images, and the decoder generates corresponding textual report. This process is typically autoregressive, meaning the model generates each word in the report sequentially, using previously generated words as a potential context. During training, we use cross-entropy loss to measure the discrepancy between the generated text and the ground truth, which is the text word embedding IDs, getting the model to improve its accuracy in generating detailed and coherent medical reports. And so here, at the beginning, researchers used LSTM as the decoder to generate report, but at the beginning, they only use one LSTM to generate the report, but we found that the medical report usually very long, so LSTM cannot generate such long report. So typically, we will use a hierarchical LSTM, which is two LSTM. The first LSTM is focused on the sentence topic, and the second LSTM will be used to generate the sentence for each topic. And then we can get a paragraph to that contains a few sentences to introduce this image. Then,
Mingjie, can I ask a question here?
Okay.
Topic generator, like how do you divide topics? Is it every type of abnormality is one topic, or?
It's a good question, because they use some tags. It will give a report some tags So you can consider it as a multi-label classification topic at first. So they will use the visual features to classify some tags, and this tags will control the topic of sentence. And then, yeah, and so it will how to contain the topic generation. And then we know that transformer comes. So everything changes from that time. Researchers start to use transformer as the decoder to generate report, but directly involve the transformer into this task will have some challenges because report generation, as we mentioned, they are sometimes repeated, lots of sentences to describe the normal images. So researchers add some memory-driven concepts to let the transformer identify which sentence or which key words they have generated. So they cannot, they will not to repeatedly generate the normal sentence. So, and this a very famous benchmark work. And here, right now, here comes the large language models. Everything become very easy in this time. You only need to give the large language model the visual tokens and the prompt. It will generate a coherent and textual inherent report. So for this work, which is the R2Gen GPT, it is a very simple idea that to transfer the image into some visual tokens and just use MLP to transfer the visual tokens to language tokens and combine it with prompt and send to the llama. It also achieved the state-of-the-art performance right now. Here, I would like to introduce, previously it was a very successful concept in the medical report generation. We can find that here, this graph is generated by Wang and his team. This graph usually contains all the keywords, like the tissues or the some disease keywords can be described in all the chest X-ray images. And then they compose these findings into this graph. We can find that the solid box are classes which have corresponding nodes in the graph, which means you can see here, they are corresponding to each other, can only relate to the line tissues. And the dotted box are organs or tissues are not part of target classes, which means we only focus on the disease keywords, but not these tissues. These tissues is only used for them to identify which kind of keywords will affect each other and how the nodes are connected to each other. And here, this circle represents the global visual features of the whole image. And they propose a graph attention with theoretical LSTM to generate the report. You can also see that here is like a multi-label classification to find what is the topic of which are the key nodes of the graph. Yeah, so it's their work. And this knowledge graph has been widely used in the following works, which has been published on the CVPR, TIMI, and AMIA. So they use this knowledge graph to enhance the visual, textual, and the visual features. Also, it also introduced a very successful concept, which is to use the retrieved reports to get some keywords to enhance the medical images. And we also follow these successful concepts. However, we found that there's a limitation of this knowledge graph. Although this knowledge graph has been widely integrated with lots of CRD systems, but we found that it cannot be updated during the training, and we found it limits the effectiveness from two aspects. Firstly, those entities cannot cover the most common disease keywords for our dataset because of the dataset bias. And secondly, entities linked to different organs can also affect each other clinically. To track those limitations, we propose a dynamic graph with dynamic structure and nodes, and integrate with visual features to generate high-quality report. And in this case, we can find that in the pre-contrasted graph, diffusion and edema are not connected in the graph, which means they cannot affect each other, or the information cannot be propagated between them during the training on the graph. However, when we read the report, we can find that they have true connections, or they did affect each other in this report. So it's very important to identify and or extract their relations from the images and update the graph to make it as a true and comprehensive graph for this case. So it's the motivation of our work. So here we will introduce the implication of our proposed dynamic graph enhanced contrastive learning approach, which we name it DCL. The overall structure of DCL is showing in this figure. You can see it contains 4 basic modules and 3 dynamic graph modules with 3 training objectives. The basic concept of our DCL is to integrate the dynamic graph with leap architectures. As we mentioned that one of the successful concepts in the report generation is to use the retrieved similarity report, but the leap can help us to find it, and we will use the retrieved similarity report to help us to construct the dynamic graph and enhance the visual features. And different from leap, we did not use the pre-training. We directly train the whole network, and we can find it achieves better performance than if you just do the pre-training at the beginning. So here we will introduce the 2 contrastive laws in our approach, which is similar from the leap. The first one is image report contrastive loss. It can active radiology reporting by encouraging the positive image report pairs to have similar representations in contrast to negative pairs. So a report encoder with the same architecture as an image encoder is utilized to extract textual representations and referring to the positive or negative report. Then we calculate the similarity between 2 CLS tokens or CLS representations by this equation, just by the dot prediction. And we also maintain 2 queues to store the most recent image report representations from the momentum image and the report encoders. After softmax activation, we can get the image report similarity and the report image similarity. And then the IRC loss can be written as this. And here we also use another loss, which is, we call it image report matching loss, to further enhance the representation learning. And this, it is a binary classification task to predict whether the given image report pair is positive or negative, matched or unmatched. So different from image report contrastive loss, we utilize a multimodal encoder to capture the multimodal representations via cross-attention mechanism. So notably, the multimodal encoder is only used during the training to improve representation learning. We will not use it in the testing or the inference. So here we will introduce how we build our dynamic graph. So we construct our graph in a bottom-up manner, in which we first construct the fundamental structure of general knowledge, and then try to add nodes or redefine their relationships according to specific knowledge. We extend the per constructed graph to our fundamental structure with 22 entities, which is 22 entities consisting of a global node represented by a class token, 7 organs or tissues, and 20 disease keywords. In addition to the link criteria in the pre-contrastive graph, every organ will connect it to each other organ or tissues because we want to focus on the organ level features. So to get the specific knowledge for each given image, we first retrieve the top 3 similar reports by calculating the similarity between the visual features and the representations of reports in Q. For each retrieved report, we extract autonomy and observations entities by lambda. Those entities are further utilized to quote the specific knowledge from RadGraph, which is a public knowledge dataset focused on the MIMIC, to explain or to introduce the relations of entities in the chest X-ray graph. And these triplets have 3 kind of relations, namely suggestive of, modified, and located at. Use different relations, we will try to add new nodes to the key word, to the disease level or organ level, or just connect the unconnect nodes in the pre-contrastive graph. So after that, we propose a dynamic graph encoder to propagate information and learn decade node features in our dynamic graph. This module is built upon the standard transformer encoder layers, and you can see it is just cross attention. It was just attention on the graph, on our graph, to extract the hidden status of each node, and we use the adjacency matrix to control the attention between each connected node or unconnected nodes. So it helps us to promise information can be appropriate correctly compared to the previous graph. And in the end, we use the graph attention to a cross attention mechanism to integrate the graph features into the visual features.
Now, Mingjie, can I ask a clarification question here?
Okay.
So you have a pre-constructed graph. You're starting from a pre-constructed graph,
yes.
And then from rad graphs, triplets. Can you, in that pre-constructed graph, is it possible to delete edges, or you just introduce more edges in there?
Here. So here is the pre-contrasted graph, which is proposed by previous works, right?
Okay,
and,
so there is no need
yeah.
to remove anything from there. It's like everything that's available is good. It's just that you may need to add some more edges.
Yeah, it is a very good question, because in this work, we just want to add more nodes for each case, and we did not remove the useless nodes. At this work, we only try to add more nodes or build new connections. But in the future work, we found that if you try to remove the unused or useless nodes, it can also achieve very good performance. So I think you have a very good question. Yeah, so I will introduce the how to remove the useless nodes in the future work section. Yeah, okay.
But I think we have one more question from the audience as well. Ramon, do you want to go ahead and ask your question yourself?
Yes. So I just wanted to understand, I think, so the rad graph seems to be kind of constraining what links you could be making in your graph. So that it uses the prior knowledge. So let's say it wouldn't be possible for your model to make the node, let's say, bone modifies lung or something that doesn't make clinical sense, correct? Or
yes, because thanks for your question. Rad graphs give us a lot of triplets to describe the relations between 2 entities. But in our model, we cannot let it automatically identify the relation between 2 entities. We can only use one language tool to extract the entities from the retrieved report. and use these retrieved entities, we will find if there are any relations or any triplets in the red graph. So we use this, we have the objective entities and the subjective entities from each triplet from the red graph, and we will use the entities that missed in the pre-contrasted graph to build the dynamic graph. Yeah, I'm not sure if I answer your question correctly.
Yes, thank you.
Yeah. Okay, so I will continue. So here I will introduce the benchmark which we used to evaluate our models. The IU-Xray, which is also known as OpenIU, is a widely used benchmark. It contains almost 4,000 radiology reports and 7,470 chest X-ray images. And in this dataset, each frontal and lateral view images are associated with each report. So to process the IU-Xray data, we have to use two image encoders to extract visual features, and then fuse them together. And for the MIMIC, which is the largest radiology dataset to date, consisting of 368,000 chest X-ray images and 222,000 radiology reports, which is split officially. It means that you can easily use the train evaluate and testing dataset to compare your method with other methods fair. And it also, there's a lot of sub-children dataset to the MIMIC, like a red graph. And recently there's also some like the chest palm, which give the lesion annotation or the tissue annotation, more detailed annotations to the dataset. And also some dataset try to remove the non-constant or the previous mentioned words from the report. So there's a lot of works you could do on the MIMIC dataset. So what are the metrics to evaluate the quality of your predicted reports? If you want to evaluate automatically, there are two kinds of metrics. The first one is the natural language generation matrix, which we call it NLG, are used to measure the descriptive accuracy of predicted reports. For example, CEDAR and BLUE are two main NLG metrics used to measure the quality of predicted reports. BLUE is proposed for machine translation task and measures the word n-gram overlap between predictions and reports. But due to the textual bias in the two benchmarks, the CRD system can achieve considerable BLUE values even when they just repeat the most frequent sentence. In contrast, CEDAR is poorly to evaluate captioning systems by rewarding topic terms and penalizing frequent terms. Also, there's some like Rouge and Meteor reported for comparison. And the second one is clinical efficacy matrix, which are recently proposed to capture and evaluate the clinical correctness of the predicted reports. It first employs the text expert to label the predicted reports into 14 different medical terminologies. And then we use classification measurements like F1 score, precision, and record to evaluate how well the generated report describes the abnormalities. And well, since the provider of IU-Xray does not use text expert to build the label, so we only calculate the CE matrix on the MIMIC dataset. So here, we compare our DCL with a wide range of existing state-of-art CRG system onto benchmarks. For example, as the R2 Gen, and CMN. They are widely used baseline models, and the KERP and the PPKED and MGSK are proposed to integrate medical knowledge with typical CRG benchmarks. CA and CMCL employ constructive learning and curriculum learning to improve performance. The performance of other baseline models such as HRGP, M2TR, and top-down are also reported. And since we follow the same settings, sometimes we directly set the results from original papers. And you can see in the table, our DCL achieved the state-of-the-art descriptive accuracy, which outperforms others in CEDAR and ROG metrics and matches their performance in the BLUE4 and Meteor. So, and here we use CEDAR as our mean matrix when we stop evaluating. So the higher CEDAR values demonstrate that our model does not repeat frequent sentence in training set, but generates report with more accurate topic. So here we also evaluate our method by seeing metrics on the MIMIC dataset and compare the performance with other baseline models. You can see this. So following the official splitting, we directly we showed MIMIC average of ROC for 14 chesty terminologies predictions and present the AUC scores in the right image. You can see Polyroma diffusion and Polyroma other achieve the highest AUC scores. And the experimental results can reveal that our DCL significantly outperforms the previous models on 3 CE metrics. So here is an ablation study to evaluate the effect of dynamic graph and our contrastive learning loss, and also the parameters which is used for internalize the whole model. And so to evaluate the effect of dynamic graph, our because our dynamic graph is constructed in a bottom-up manner that exploits general knowledge from per constructed graph and the specific graphs extracted from retrieved top 3 similar reports. So comparing with the base model, you can compare. We can compare the sightings A and B. Our dynamic graph can boost the performance of base model substantially. And more specifically, leveraging the general knowledge only lead to an increase on all LG matrix by, you can see, by 15.2% on CEDAR and 1.1 on BLUE4. And also by integrating specific knowledge, our dynamic graph can further boost the performance, like 0 from 535 to 557 on CEDAR. It demonstrates that the effectiveness and to construct dynamic graph for each image. We found this performance improvement maybe due to that the dynamic knowledge can infer keywords when generating reports, since dynamic nodes are from retrieved reports. We can also find that if we compare the sightings B and C, we can find how IRC and the IRM loss boost the base model performance. So to further explore our work, we do a case study. We perform the qualitative analysis on MIMIC with their retrieved specific knowledge and the report from ground truth, our model, and also the predicted reports from our model and R2Gen, which is a very famous baseline model. Entities extracted by standard from the ground truth report have been highlighted with different colors. We can see that like cap, consolidation, and pseudonotomy are not included in the pre-constructed graph node list. So this observation proves our motivation for constructing knowledge graphs dynamically. So we conduct the same operation on retrieved reports and use extracted entities to quote related triplets from red graph. Those triplets are known as specific knowledge in this paper and also known, and you can see here, here is a retrieved specific knowledge. So use this knowledge, this retrieved specific knowledge triplets can demonstrate that the retrieved report contains similarity medical terminologies and clinical information. We subscribe that IRC and IRM objectives bring such capabilities. Then the entities in our dynamic graph infers disease organ keywords when generating reports, and it is why our DCL can predict sentences like airspace consolidation is noted when the left upper lobe compacted with pleurotomy, but R2Gen cannot. So it is the advantage of our model. So here I would like to introduce the future work of future work. So the first future work is how to we want to discuss how we enhance the contrastive learning with a new concept, counterfactual features. So the concept of counterfactual has surfaced in machine learning as an insightful tool to comprehend how models' decisions can be changed when you ask him a question. So the counterfactual features offers an alternative to the observed data, allowing for the assessment and the comprehension of models through what-if scenarios. This technology has been integrated into diagnosis models to not only improve diagnostic accuracy, but also enhance their explainability. So we aim to make this progress further interactive and explainable by explaining the global feature changes in specific local regions, because we mentioned that one of the key challenges in our task is the small regions, right? And we want to find how can we enhance the local visual feature representations. So we propose a counterfactual as what if we exchange the patch between two images while the diagnosis shift. So for example, if we got a factual image and we found another negative image, if we change the patch here, which at the same location, well, it get another or a different predicted diagnosis. If it changes the predicted labels, does it mean each part can contain the most important features for the global feature? And we should put more attention into these local regions, right? And here is an overview of our work to how to build the counterfactual features to generate the new report. And this paper is reviewed in the ECCV, and we are still waiting for the final decision. So, so we will publish the code with this. We have already published the DCL code, and we will also publish code after the final decision. And here is a very interesting work. It's just mentioned by Camera. So at the beginning, we just try to add more nodes, and we found it's quite, so it's lots of engineering work in our method, in our DCL. And we found how can we simplify this model and make it more easy to follow and straightforward. So we found that given a report, why we just use the mentioned nodes, but not all the previous or all the pre-contrastive graph with our trying to add the this concept from if we just try to add some nodes because they are mentioned, so they are useful. In the pre-contrastive graph, some nodes are not mentioned, which means they are useless. Can we just remove them So we just simplify this task into a multi-label classification. We do a very interesting experiment that we only use the ground truth node, which is the measure node from the pre-contrasted graph, to do the cross attention with the image features. And we found it achieves a very seeding performance. It almost outperforms all the current CRG method, like they can double their performance metric values. So it's a very interesting finding, and we just try to make it work and in the current right now. So I did not show more details, but the concept is to, because right now we all everyone use large language models as decoder to generate report, right? And the most important to use large language model is to give him a very good prompt, right? And if this prompt can contain these keywords, the large language model can help us to generate a very, very good report. So right now, the medical report generation task has been simplified into a multi-label classification task. So when we review this task, we found everything become easier right now. The only thing you need to do is to do a very good classification problem and let the large language model to solve the rest for you. So I think the time changed. So everyone, but this concept has also been used in some existing works like the prompt MRG. They use some classification to do the more labels, but we found that if you only use the pre-contrastive nodes from the pre-contrastive graph, it can also achieve the seeding performance. Yeah, it can be easier and simpler to end this task, maybe. And so that's all for today. Thank you, everyone. And if there's any other questions.
Thank you very much, Mingjie. It was a very interesting presentation. So everyone, let's give our speaker a virtual round of applause. And then floor is open for questions.
Thank you.
I can start with one question on basically the background of this report generation field that you introduced. You said there's a lot of problem with data homogeneity. I mean, all of the chest X-rays, they have a lot of visual similarity, and then all of the reports, they have a lot of kind of templated text, so they're very similar to each other. Do you think like those, all of the negative, I mean, did you do any attempt in reducing that homogeneity? For example, all of the normal reports, they usually just list a bunch of this is normal, that is normal, that abnormality is not bound. But do you think that is kind of useless information, which even if it is not generated by your model or an automated system, it would be fine? So do you try to drop those sentences, or you just take the report as is?
Thanks for your question. It's a very good question, because in medical report, we found that there's lots of sentences which being used to describe the normal finding. We try to, but the most, as we thought that the sentence to describe abnormal findings is very important. However, in the clinical practice, when we talk to the radiologists, they said they have been taught or forced to write report in this way to introduce all the normal findings, because they will write this report in a specific template to avoid missing any important parts. So you can consider that when they try to write this part as normal, they review this in a certain order to make sure they did not miss any important things. So if we just let the model to describe the abnormal things, it means if you just send the abnormal description to the radiologist, they still need more time to read all the images. They have their order in their mind to read this image, and only when they read, oh, this part is normal, oh, I know it cannot be this disease. That part is normal and will cannot be another disease. So this part will be also very important for the normal descriptions, even they are just not friendly for the machine intelligence system, but they are very important in the clinical practice. So some researchers try to build another model, which they will use a classification or some method to extract the keywords or the key features or the key organs. And then for each organ, they will do a classification to identify it is normal or abnormal. And use this, they will to generate the report. So there are different works try to solve this problem, but we have to keep the normal sentence in the predicted reports.
Yeah, that's very interesting. But do you think since those sentences would be repeated a lot in any data set, the model would probably find it easier to generate those sentences. So do you think that there's any innovation needed at the evaluation level where we not only evaluate the model for just like word for word similarity with the ground truth, but also like was it able to write the more important part, which is an abnormality, or was it just repeating all of the normal findings?
Yes, thanks for your question. And right now, some researchers just mentioned your ideas that the current matrix cannot perfectly evaluate the quality of predicted reports because we want we want them to focus on the abnormal things, but the ALG matrix only focuses on the textual similarity. And so that's why we use CE matrix to do the classification, because CE matrix will use the chess expert to extract the key, like the disease keywords or the labels from them. And we will do the classification to identify if the report contains some key abnormal disease. It is the first part. And also right now, some researchers try to employ the CE metric with the NLG metric. When we calculate the textual similarities, those abnormal sentences should achieve more attention or more scores or more weight than the normal sentence. So they are also trying to build this, but there's not a benchmark metric for to use this, but still some works are trying to do this. Yeah, thank you.
Thank you very much. So do we have any more questions from the audience? If not, then let's give our speaker another round of applause. And if anyone has any questions later, we can put them in touch with the speaker. Thank you very much, Mingjie. It was very interesting.
Thank you. Thank you.
Thank you, everyone, for joining us.